Good day and welcome to today's live Q&A session. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to submit a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn this call over to Melissa Dorsey. Please go ahead.
Hi, good afternoon, everyone. My name is Melissa Dorsey, and welcome to the live Q&A session associated with the CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home and Management Training Series. The live Q&A sessions are dedicated entirely to interacting with the participants, sharing comments, and taking questions, and are intended to supplement the online training topics and provide nursing home personnel with an opportunity to ask questions of CMS and CDC as they navigate through the pandemic. Thank you for taking the time today to be here with us, and a special thanks goes out to our CDC fellow colleagues for partnering with us on this important training series. The slides for today are available on the QIO program website, and the recording from today's event will also be posted there within the week, so be on the lookout. Next slide. Please be aware, registrants of the training series can email the nursing home training inbox for support with certificates, self-assessments, or issues accessing on-demand training. Next slide. It is now my pleasure to introduce some of our featured colleagues on the call today to assist us with answering the questions you may have. Today, we are fortunate to have the following CDC colleagues join us: Dr. Molly Stone, Dr. Cara Jacobs-Liska. We are also joined by fellow CMS SMEs and cores, Angel Davis, Marianne Butcher, Nancy Allert, and myself, Melissa Dorsey, along with a few co-workers from the Division of Nursing Homes within CMS, Kathleen Lawrence and Sheila Hahn. Welcome to all of you, and thanks again for joining us today. We received a few pre-call questions that we plan to address and discuss today, so thank you so much for your submissions. We would like to also encourage you to get involved in posing questions to address while we're here live today. So please enter your questions in the Q&A box located at the bottom of your screen, and we will answer and address as many as we can as the time allows. So without any further ado, let's get started. So now I'm going to pass this call to Angel Davis to kick off our Q&A session. Angel?
Thank you, Melissa. Our first question today is for our CDC colleagues, and this question is related to NHSN. Is it mandatory for the flu information to be sent on the NHSN site?
Hi, everyone. This is Namali. Let me just say a couple of words about the opportunity that NHSN is making available for long-term care facilities, both nursing homes and assisted living facilities. There are new options to report, to track and keep an ongoing report of the influenza vaccination coverage that is occurring among healthcare personnel in your facilities. And I think this is a really important opportunity because, this year in particular, we really want to do everything we can to reduce the risk to residents and staff for respiratory illness. And certainly, given what we're still continuing to see with COVID, we want to be as proactive as we can to reduce the potential for co-circulation or dual outbreaks of influenza and SARS-CoV-2 in centers. So this tracking option allows the center to, over time, capture the expansion of vaccine acceptance among healthcare personnel. There is also going to be an option for residents, and forgive me, I have to check and see if that is already available, but these are not mandated at this time, and so it is an optional tracking capability within NHSN that I would encourage you to take advantage of, especially if it allows you to kind of organize and maintain an ongoing record of flu acceptance and coverage among your residents and staff. This is, I know that MDS, for example, does capture influenza vaccination offering, as part of the quality measures, did you offer, as well as was it accepted? But as you all know, this happens on a quarterly basis, and so the advantage of NHSN would be that this is more real-time data tracking. But to answer the question, no, at this time, that kind of reporting is not mandated. It's just strongly encouraged. Thanks.
Thanks, Dr. Stone. The next question is for the CMS Division of Nursing Home staff. It's a two-part question. Are outdoor visits allowed when outbreak testing is going on? And when a resident is positive for COVID-19, can they go outdoors to visit?
Oh, hello. This is Kathleen Lawrence from Division of Nursing Homes. So for the first question, outdoor visits may be able to occur when outbreak testing is going on. A facility outbreak would be a factor that a facility should consider with regard to outdoor visitation, along with other factors such as the weather and a resident's health status. So outdoor visitation may still occur depending on the type of outbreak the facility is experiencing. For example, if an outbreak consists of one staff member who is now on leave and no other staff or residents are experiencing symptoms, outdoor visits could probably still occur with adherence to the core principles of COVID-19 infection prevention that we listed in the visitation memo. And conversely, if there's a larger outbreak and the facility is still working to contain it, outdoor visitation may need to be suspended for a limited period of time. And it's the second part of the question about when a resident is positive for COVID-19, can they go outdoors to visit? Well, that resident would be on transmission-based precautions. So we would say that they would not be permitted to go outside until they've gone, till a 14-day period has ended for their transmission-based precautions.
Thank you. This next question is for Dr. Kara Jacobs-Lipka, and this is concerning admissions and readmissions and observation units. What is your recommendation for the facility that continue to admit new residents in a semi-private room versus being in a single room?
Thank you. So our recommendation is that depending on the COVID-19 prevalence in your area, you place those newly admitted residents into either a single person room or into an observation area. And so a single person room with a separate bathroom, that's definitely preferred, as that newly admitted person may have had a COVID-19 exposure. And so separating that individual from others helps to minimize any potential risk of transmission of SARS-CoV-2, the virus that causes COVID-19, should that resident go on to develop an infection. But we also recognize that many nursing homes just don't have that physical space to accommodate single person rooms for all of those residents. So if you must place individuals into semi-private rooms, I think the lesser number of residents, the better. So having 2 people in a room as opposed to 3 or 4. And you also want to be really careful if you need to place those individuals into rooms with others, that you're avoiding putting a newly admitted resident into a room with someone who's symptomatic, for example, or someone who is has a known close exposure. And you definitely don't want to put those newly admitted residents into a COVID unit. You want to avoid inadvertently causing exposures should either that newly admitted resident go on to develop COVID, or should another resident that's already in the building go on to develop COVID. You don't want those new roommates being placed together to expose one another. So you want to try to avoid putting people together who have different types of exposures or having symptoms. Thanks.
Thank you so much. Our next question is another NHSN question for Dr. Stone. Reporting into NHSN is tedious. Are there plans to allow facilities to submit in a spreadsheet format rather than one point of care antigen test result at a time?
Yeah, thank you for that question, Angela. I will absolutely acknowledge that the current, resident level data entry for point of care antigen test results is pretty tedious. That's a fair way to describe it, because even when the residents' names can be quickly autofilled or selected from a drop-down, the first time you're entering everything, and then subsequent times you still have to go into each individual resident's result to submit it. There is a plan underway to develop the bulk electronic upload capability using like a CSV file format similar to what is available in some of the other COVID pathways. And so the NHSN team recognizes that that's a need, and they are working on developing that capacity so that a center could, upload a batch of results into the system. As you all know, that there's some programming that goes into identifying all the different fields that have to be included, and making sure that the electronic upload goes correctly into the system. And that does take some time. And so it won't be a quick capacity functionality that's going to be offered. I have heard colleagues from the team say that because of other development priorities, that electronic upload capability for the point of care antigen testing is unlikely to be available before the first of the year. And so I hope you will bear with us while we're still working on that, but we are doing our best to create that functionality. Thanks.
Thanks, Dr. Stone. The next question goes back to the CMS Division of Nursing Homes. The question is, what about outdoor visitation for a facility in an area with above 10% positivity rate, not in an outbreak situation?
Okay, well, thank you for that question. So the recent CMS memo on visitation, QSO 2039, states that positivity rate does not need to be considered for outdoor visitation, only for indoor visitation. So outdoor visitation and compassionate care visits should still occur regardless of county positivity rates. For outdoor, as I mentioned before, you'd want to still consider some of those factors like an active outbreak, the weather, the resident's health status. And that's it. Thanks.
Thank you, Kathleen. This next question is for Dr. Jacob Slipka. Is it still required to have residents on a 14-day quarantine when being admitted from the hospital when they have a negative COVID-19 test?
Yes, thank you. So we do make the recommendation that depending on the prevalence of COVID in your community, that you are placing residents in a single person room or in a separate observation area, and that you're caring for them using all the required transmission-based precautions, even if they have, whether they have testing or not. So it's important to remember that a test result, a negative test result, really only reflects a single point in time. So if that resident has had a negative test result at some point during their hospitalization, or even if it's either at discharge from the hospital or when they're being admitted to your facility, it is still possible that they could have had an exposure to someone with COVID-19 up until that point, or possibly even during the transition or transportation from the hospital to your facility. And so they may potentially, during the next 14 days, go on to develop infection. So having had a negative test, even right at the time of hospital discharge or during their hospital stay, doesn't that they still could go on to develop infection. So we do still recommend that even with a negative test, they would be placed into observation for 14 days, and that they're using that transmission-based precautions. Staff are wearing an N95 or higher level respirator or face mask if a respirator is not available, gown, gloves, and eye protection. Thanks.
Thank you, Dr. Jacobs. The next question is for Dr. Stone, and it's around testing. How important is turnaround time for testing results? And what should be the standard for testing result turnaround?
Hey, this is a really good question. It's an important one. Our mantra has always been, the faster you get test results, the quicker you can implement infection prevention precautions and practices. That might include placing individuals into a designated COVID care area if they've now confirmed positive. It may be expanding testing to other residents and staff that may have been exposed to a new confirmed case. So the faster you have data to work with, the better. And we know that back in the early part of the pandemic, we saw real difficulties with containing SARS-CoV-2 outbreaks in nursing homes because of substantial testing delays and just really limited testing supplies. The recommendation is to have results within 48 hours. That's that would be on the most amount of time though that you really want to have to wait to get a result. I think with the point of care antigen testing, platforms now available, that really gives us much faster opportunity for response. I think more diagnostic testing platforms are going to become available at the point of care. That'll be other fast viral diagnostic tests. And so ideally, you are getting a result to respond to or start to respond to within 20 minutes, 15, 30 minutes of doing the swabbing. However, less than a day, within 24 hours would be the optimal, and certainly the standard should be within 48 hours. Thanks.
Thanks, Dr. Stone. I've got a follow-up question for Kathleen at CMS on outdoor visitation. Can you please repeat if you can allow outdoor visitation during an outbreak? I read it as that you cannot hold any type of visitation until you've had 14 days cleared.
Okay, sure, I can answer that one. So the way the outdoor visitation is described in the memo, we list things that should be considered in order to permit outdoor visitation. We really want outdoor visitation to occur. So an outbreak would be a consideration. So we think depending on the outbreak and how the facility is dealing with it, containing it, outdoor visitation could still occur. So, and I gave, I think, an example earlier of like one staff member, for example, and then that staff member is not in the facility anymore. And of course, the facility would be doing outbreak testing, but as long as there are not a lot of staff or residents with symptoms and everything seems contained, there's no reason you couldn't still have outdoor visitation going on. But if it's an outbreak where, you know, it's a large number of individuals that are showing symptoms and the facility just needs to get things under control, then yes, you might need to put a pause on the outdoor visitation so things are more contained.
Thank you. This next question is for Dr. Jacobs. While residents at nursing homes are being worked up for acute febrile illness, would it be prudent to move them into a dedicated unit for PUIs? Any suggestions on using an index of suspicion criteria in such cases in terms of transfer to PUI COVID area versus practicing transmission-based precautions and letting the resident remain on the unit where they previously were?
So are a couple of important points, I think, to keep in mind here. Our current guidance recommends that when you have a symptomatic individual, things that you want to be thinking about are trying to figure out, one, why this person is symptomatic. So doing things like testing that person for COVID-19 or possibly even considering other diagnoses. But the other is to prevent this possible spread. In this case, we are thinking about SARS-CoV-2. And so putting them in transmission-based precautions to try to avoid any possible spread. So that's one of the key goals that we're thinking about. So we do recommend that they're moved to a single person room if possible. But as I mentioned earlier on the call, this isn't always possible to do. And so things that we don't want you to be doing, we wouldn't recommend that you're moving, ideally, you're not moving this individual in with another symptomatic resident. We have seen throughout this outbreak that just because someone has symptoms doesn't necessarily mean that they're going to test positive. We've seen in some outbreak settings in nursing homes that, you know, it might be around 30% of people or so, but that could differ, you know, by situation, who have some kind of a symptom that is concerning for COVID-19 actually may end up testing negative and don't have COVID-19. So ideally, you don't want to move them in with someone else who's symptomatic. You definitely don't want to be moving them into a dedicated COVID unit where there are individuals who have been confirmed to have COVID-19, because at this point, you have someone who has an acute febrile illness, but you don't know yet if they have if they have COVID-19. And the other thing that you want to be, you want to try to avoid moving this individual who's symptomatic in with someone else who has a possible exposure. So if it's going to, if you don't have a single person room available for them to move to, and you don't have the ability to move them somewhere where without moving multiple other residents in order to accommodate doing something like that, it may be, the best approach may be to keep them where they're at, to shelter in place, put them in transmission-based precautions, get their results back, and then make your further decisions from there. Thanks.
Thank you, Dr. Jacobs. The next question is for Dr. Stone, and it's related to testing. If we have someone working in the office, such as human resources, test positive for COVID-19, but they have not had any contact with residents, and we are already testing all employees weekly, do we need to test residents?
So this is a fair question. I think it touches on a few issues. You know, one is looking at exposure and doing kind of like a contact tracing to understand just who exactly may have been at high risk when a new individual is confirmed to have COVID-19 infection. And there are a few factors that play into this. One, as the individual who asked the question raises, we are doing a lot of screening already, and I think one adjustment issue I would possibly add is, we are realizing that the faster we find new infected individuals, the asymptomatic infected individuals or pre-symptomatic people who haven't yet developed symptoms but are going to, the faster we find those folks and address, the appropriate infection prevention practices, like for staff, for example, furloughing them, until they have recovered, or for residents, placing them in a dedicated care area and handling them with full precautions. The faster we do that, the smaller the size of outbreaks tends to be. So some of our guidance is moving us more toward not waiting even, our guidance, I think on the website says 3 to 7 days to do repeat serial testing. I'd say there's a growing body of evidence that would support more frequent, so every 3-day testing intervals, as opposed to every 7. There's just this window of time, especially early when there's a new case occur, that's detected and a new potential exposure being evaluated. The faster, the more frequent you look, the better your ability is to find any other infected individuals and move them into safety. Another factor that might come into play with this is how much capacity to do testing do I have? Are there any, limitations on my supplies, the reagents, things of that nature? The current guidance would recommend broader testing in the event that a staff person is identified as COVID-19 positive. We are continuously evaluating and learning from the experience with providers to make adjustments to that. And we also talk frequently to state health departments and local health departments to get their insights into, how they are approaching these circumstances where the level of exposure appears to be less for residents because of the person isn't working in a resident care area. But the caveat is always how much cross interaction or potential for cross infection was there between staff members. And that's one of the pieces that we're getting a lot better at, but we still see that our healthcare team members, they just sometimes forget, that when they're interacting with one another, they have to be as cautious and as diligent with things like using a face covering and staying separated by 6 feet, that spatial separation. We make, little lapses in those activities. And I worry, honestly, a little bit that because people are getting tested on a regular interval, they might actually develop a bit of a false sense of security. As Dr. Jacob-Slifka mentioned earlier, a test is a single point in time. And just because I test negative for SARS-CoV-2 on Monday, it doesn't mean that I'm not incubating it and potentially infectious on Wednesday or Thursday. So we don't want our staff to become a little too comfortable with their other infection prevention practices and perhaps get a little, lax about them because they think, oh, well, I tested negative, I don't have this. So for that reason, I think we still need to work with the health departments, think through, are there any direct care staff that could have been interacting with that person in HR that could be a portal of exposure for the residents in the center? And that's why I don't think we can say a blanket yes or no to that question, but those are some of the considerations that you have to go through in order to make that decision. Thanks.
Thanks, Dr. Stone. The next question goes back to Kathleen at CMS. If the positivity rate in nursing home is over 10%, should there only be compassionate care visits? The Ombudsman is saying that essential caregivers can go in to visit regardless of positivity rate, as long as the person they wish to visit is not positive.
Okay, that's a good question. So the CMS memo on nursing home visitation states that if the county positivity rate is high or greater than 10%, visitation should only occur for compassionate care situations and, of course, be conducted with the core principles of COVID-19 infection prevention that are described in the memo and facility policies. So the CMS guidance does not distinguish between visitors categorized as essential caregivers or other visitors. We think that using a person-centered approach when applying the guidance should cover all types of visitors, including those who have been categorized as essential caregivers. So visits for compassionate care situations are the only type of visits which should be occurring when the county positivity rate for the nursing home's location is greater than 10%. So I hope that clarifies that.
Thank you, Kathleen. This next question is for Dr. Jacobs-Lipka. This is concerning PPE, a popular question. Does full PPE need to be worn when delivering meal trays in rooms of those residents who are in isolation or quarantine?
Thanks. So I definitely appreciate this question because I think a lot of the questions about PPE have tended to focus on the staff who are providing close contact direct care for residents. And so this is asking specifically about delivering meal trays. There are a couple of points though that I want to make. I think the first one is that when we're talking about a resident with confirmed COVID-19 who is on a dedicated COVID-19 unit, our recommendation is that as much as you are able to do so, you are dedicating staff, clinical staff to that unit, environmental services staff if possible, but that you try to avoid sending other individuals onto that unit. So, for example, what you might do is meal trays would be delivered to that unit, and then the staff who are working on that unit would deliver those trays to the residents just to avoid other staff from needing to go onto that unit where residents are known to have COVID-19 and going in and out of rooms. So now that's it. In other units of the building, or if you have residents who have COVID-19, you're in a situation where there's a lot of activity in your building and you've got individuals throughout the building, or in situations like an observation unit, for example, where residents are on transmission-based precautions, that may not be feasible. So technically with transmission-based precautions, and this would even be outside of COVID-19, when you're thinking about contact precautions or droplet precautions for other pathogens, anytime someone's on transmission-based precautions, the ideal practice is that you are using all of those recommended or required PPE for anyone who is entering the room. But what we've seen during this pandemic is that with supply shortages, we have had to make some difficult decisions about what PPE is being worn in and out of the room. And so, for example, with gown supplies, when there are anticipated shortages or actual shortages, some of the strategies to optimize gowns that we have recommended have included things like prioritizing gown use for activities that have closest contact. So for situations like delivering meal trays or for other situations where there is less anticipated contact, when you have shortages in gowns, for example, those may be situations where the staff involved are wearing the rest of the required or recommended PPE, but gowns are prioritized for the staff that are going in and providing that prolonged close contact. Things like hygiene, bathing, toileting, changing sheets. So that's kind of two different explanations for different settings within your building, and a part of the decision making here will need to be around your PPE supplies. But regardless, everyone should always be using at least some kind of face mask, universal source control. And if you're in an area where there is at least moderate or substantial transmission of COVID-19, everyone who is going into those patient or resident care areas should be wearing eye protection as well. Thanks.
Thank you, Dr. Jacobs. The next question is another testing question for Dr. Stone. Any recommendation for staff with mild illness, such as headache or runny nose, who test negative for COVID-19 via the rapid test, PCR? When and under what circumstances can they be allowed back to work?
Yes, it's a very important question, especially as we're going into the respiratory viral season. And so here's how I would approach this. If you're starting to see influenza circulating in your community, then in addition to testing for, COVID-19, I would also recommend testing for flu. And that is because we know, there's such an overlap in the signs and symptoms that those two viral infections can present with. And they're both viruses that we don't want to introduce into the resident population. I mean, really, and I'm sure several of you have seen this in your own experience, even the seasonal coronavirus or viruses like respiratory syncytial virus, RSV, that we typically think of as more of a problem in neonates and infants, can cause very substantial, serious outbreaks with a lot of hospitalizations and even deaths in a frail, older nursing home resident population. So no respiratory viruses are good to come into our buildings. But we are focusing a lot, and there will be guidance coming out to sort of help providers think about how to deal with the risk of co-circulating influenza and SARS-CoV-2. But if these are ruled out, then you follow your usual standard return to work policy for respiratory illness. So resolution of any fever. In this particular example, there wasn't fever, and improvement in symptoms. 48 hours is generally the rule of thumb, and so that would be the approach to somebody who tests negative. You've ruled out SARS-CoV-2, and if you've ruled out influenza and they're recovering and better, that's typically what most return to work for people who have otherwise fairly mild symptoms like this. Thanks.
Thanks, Dr. Stone. The next question goes back to Kathleen at CMS. How many visitors can visit at one time with plexiglass? For example, can two sisters visit their mom at the same time?
Okay, thank you. So for that question, in our guidance, we really didn't provide a specific number of visitors per resident because we know facilities can vary in their physical setup and space for outdoor and indoor visitation. So we did state when conducting outdoor visitation that facilities should have a process to limit the number and size of visits occurring at the same time, so that they can support safe infection prevention actions like social distancing. And then we also recommend reasonable limits on the number of individuals visiting with any one resident at the same time. And again, that's kind of going to depend on the space that each facility has set up. For indoor visits, we also recommend limiting the number of visitors per resident at one time and limiting the total number of visitors in the facility at one time based on the size of the building. And then facilities may want to also consider scheduling visits for a specified length of time, and that's to help ensure that all residents are able to receive visitors.
Thank you, Kathleen. The next question is for Dr. Jacob Slipka. This is concerning PPE. Is universal eye protection used only during patient care in locations with medium or high transmission, or should universal eye protection be used similar to universal source control, meaning at all times?
Thank you. So right now, our recommendation is that universal eye protection is used during patient care in areas where there is at least moderate to substantial transmission. However, we also do have there are a couple of other important situations that I think you need to keep in mind. One of those is that under standard precautions, you still, at any time and for all residents, need to be thinking about potential exposure to blood or body fluid, anticipated splashes or sprays, that kind of thing. So if that is at all anticipated, or if there is any concern, wearing eye protection or any other PPE for that matter is definitely appropriate. And then the other situation where we do specifically talk actually about universally using eye protection are on units like memory care units or places where you have concern that there will be numerous residents who may not be able to remain restricted, to their rooms in a setting where you're using transmission-based precautions, like an outbreak setting, for example, where staff may encounter residents throughout the hallways or other areas. In those situations, we do actually say if there are residents who've tested positive, that you may want to consider universally using eye protection in those situations. But with eye protection, as long as you are using it appropriately and you are trying to avoid touching it, because you do want to think about that surface of the goggles or face shield as being contaminated, washing or cleaning your hands if you do. That is PPE that can be used. Thank you.
Thanks, Dr. Jacob. The next question is for Dr. Stone, and it's pertaining to testing as well. Can you discuss the outbreak testing requirement of every 3 to 7 days? How do you decide if you should test every 3 versus every 7 days? And how close does the last testing day need to be to the 14th day testing period to determine there are no new positives?
Great. So we started to talk about this a little bit already, but I think it's really helpful to talk, to kind of review the recommendation for serial testing and some of the thinking behind the time parameters. So this is the serial testing that's occurring among people who were initially SARS-CoV-2 negative. When you're doing expanded testing in the context of an outbreak, so you've got a confirmed case, and what you're trying to do is very quickly identify any additional infected individuals that could be harboring the virus, but not yet manifesting signs and symptoms. And we've talked about before that, that there's a 14-day window from when somebody is exposed to somebody, with the virus and has an exposure to when they could kind of have infection and be incubating it before they develop symptoms. So, as I mentioned earlier, the faster we are able to do that repeat serial testing, the more effective our infection prevention practices can be, and the better we are able to contain the spread. That's why we are really encouraging centers to do every 3-day testing, especially if they have, better testing capacity with better access through the point of care antigen testing platforms or through, PCR testing, because in that very early exposure window, that is the most critical time to find those, asymptomatic or pre-symptomatic folks. And if you're testing every 3 days, then especially in that first week, from the confirmed case being detected, when you start your screening, that's probably the highest risk window. Then, if you have the capacity to continue with the Q3 days for the entire, 14-day period, what you're trying to do is prove that there are no other infected individuals, and you want to make sure that no new infected individuals are identified in your center for a 14-day period of time. And so if nobody had it but that one case, and your containment has been really effective, then if no new positive cases are identified after 14 days of serial testing and every 3-day cadence, that's when you can stop the serial testing. But let's say that you have an individual who does test positive, a new case is identified in that first week. Then you want to go out from that last positive 14 days without any new people. And I think what generally centers do is do the Q3 days, serial testing early. And then when they've gone, 7 to 10 days without a new case, they can shift toward, every week if they need to. So it's the most important to do the frequent testing when that first case happens, and you're really aggressively looking for additional infected individuals at that point. So hopefully that answers the question and gives some of the explanation for why you want to go a full 14 days without seeing any new positives before you stop the serial testing. Thanks.
Thanks, Dr. Stone. The next question goes back to Kathleen at CMS. Does the nursing home CLIA waiver allow us to test family members that would like an indoor visit? Can we use our CLIA waiver to test other personnel that are not our employees?
Okay, so as far as the CLIA waiver, as long as the facility has a CLIA certificate, they can test anyone that the facility chooses. The CLIA waiver and certificate is not prescriptive about who can be tested. We just require that any facility performing diagnostic or screening testing be CLIA certified. Hope that clears that up.
Thank you, Kathleen. This next question is for Dr. Jacobs-Lipka about PPE. If ample supply of reusable ISO gowns are available, would it be appropriate to treat each individual suspect or confirmed COVID-19 with its own gown, or could a few co-hosted patients be treated with the same ISO gown?
So, so yes, if you have no anticipated gown shortages and you have the supplies to use a separate gown for each resident encounter, then this is definitely the recommended practice. The reason that we have PPE optimization strategies that may include practices like extending the use of gowns or gown reuse is because of the shortages that we've seen during this outbreak and the need to make some really difficult decisions about how we're prioritizing gown use and other PPE use. So I think it's important to keep in mind that crisis capacity strategies, those strategies that include things like extending the use and reusing gowns, these are not considered to be commensurate with US standards of care. So, as soon as you no longer need to use those strategies, you should go back to more normal gown use strategies. And this is something we strongly recommend. So, regarding the question specifically about using the same gown for multiple residents, if you don't need to do this, then we recommend that you avoid doing that. So that, but that practice is, we consider that to be, or we call that, we refer to it as extending the use of a gown when you're using the same gown for multiple residents. It is one of the crisis capacity strategies, like I said, that should only be used when you don't have enough gowns and should really only be used when you have residents who have the same infectious pathogen. So, such as when residents are confirmed to have COVID-19 in a dedicated COVID unit. They're in the same area of the building and they all have the same pathogen. You don't want to extend the use of gowns when one of those residents has another infectious pathogen. So if one of those residents, even on the COVID unit, also had C. diff, you don't want to extend the use of a gown, including for that resident. Or if residents are known to be colonized with something like Candida auris, for example. And we also urge you to use caution when you are using practices like extended use or reuse, as they have the potential to place both the healthcare provider, that healthcare personnel, um, at risk of self contamination and may potentially contribute to the spread of pathogens such as Candida auris or a highly resistant bacteria. Thanks.
Thank you, Dr. Jacobs. We only have a few minutes left, but I think we can try to squeeze in one last question about testing for Dr. Stone. Can you please confirm if a previously tested positive patient who was exposed to a positive individual does not need to be placed on quarantine for observation, provided that the exposure is within the 90 days from testing positive?
Thanks, Angel. The answer is yes. What the way the question was framed, what the scenario is that they described, they are correct. When you have someone who has recovered from COVID and they are within 90 days from that initial infection, we do not recommend retesting those individuals within that 90 days. And we don't recommend, placing them back in quarantine or transmission-based precautions, and because we have data that shows these individuals are very unlikely to experience reinfection in that initial 90-day window from their first infection. So one kind of caveat to that would be if that individual developed new signs or symptoms that were consistent with COVID-19 and had no alternate explanation for those signs and symptoms. Thanks.
Thank you, Dr. Stone. Next slide, please. Please join us for the next live Q&A session on November 19th from 4 to 5 p.m. Eastern Time. Registration is required, and we will put the registration link in the chat for your reference. Next slide. Thanks again for your participation in today's call, and thank you again to our Panelists, we hope you found value in the topics discussed. Please take a moment to complete the survey from today's event. We use this information that you shared to improve future sessions. Please have a wonderful day. Thank you so much.